Hi, today we are going to discuss polytrauma with liver tear. So, a 30-year-old motorcyclist came with RTA in A&E. On examination, pale, dry skin, cold periphery, hypotensive and tachycardic. Skeletal survey show multiple fractures with bruises. The abdomen is standard with multiple bruises noted in the right flank area. Fast scan showed free abdominal fluid. Chest X-ray and CT were done, which will be shown to you. You will be asked further question regarding this patient. So basically, this is a trauma case as we receive in our hospitals, and this patient is presenting with shock, most probably hemorrhagic shock or hypovolemic shock. Okay, what's the questions? How will you manage this polytrauma patient? I will call for help to trauma team anesthetist and manage the patient according to ATLS protocol, according to CABCDE manner. So what is small c? Control of exsanguinating external hemorrhage. So if there is exsanguinating external hemorrhage, so first you have to control this. This will get reversed. So if there is no exsanguinating external hemorrhage, then you can go straight forward to ABCDE protocol. So A is airway management and control of cervical spine. So I will first speak to the patient. If patient can speak, secure airway will give 12 to 15 liter O2 per minute to maintain saturation 95%. So just speak to a patient. If he can speak, this means that he airway is okay. If patient can't speak, look in the mouth for foreign body and in the face for maxillofacial injuries. Feel the breath on your cheek. Listen to abnormal breath sounds. Stridor or hoarseness management. Remove any foreign body in chin lift or jaw thrust. Oronasopharyngeal airway. Endotracheal intubation. Cricothyroidotomy. Tracheostomy. Embolize the cervical spine by hand. Hot collar plus sandbag plus tape. Triple immobilization technique. Hot collar, tape, and sandbags. Okay, so these are some important tricky points for management of airways. Non-traumatic patient chin lift. So in non-traumatic you can chin lift, since if there is a C-spine injury, so you can't do chin lift maneuver, it will damage the cervical spine. So with a traumatic cervical spine injury, unknown mechanism, so we do jaw thrust in those patients. If no gag reflex, base of skull fracture or pharyngeal airway. If no improvement, then ETT, endotracheal intubation. Cricothyroidotomy in depression between the thyroid and cricoid cartilage, lower half of thyroid membrane. Tracheostomy, second and fourth tracheal ring, midway between the thyroid notch and the suprasternal notch. What are the foreign bodies do you expect? Foreign body can be found broken teeth, vomitus, denture, food particle, blood clots, metallic foreign bodies. Okay. So the second part is breathing and ventilation. So assessment, inspection. Any obvious chest injuries, open wounds, fly segment count, respiratory rate, symmetrical chest wall movement, palpation, central trachea, surgical emphysema. You will feel crepitus if there is surgical emphysema. Percussion and auscultation for obvious hemo or pneumothorax. मैनेजमेंट किस तरह करेंगे? हाई फ्लो O2 थ्रू नॉन ब्रीथेबल मास्क, नीडल thoracostomy or chest tube, occlusive dressing for open pneumothorax. Like you have to put occlusive dressing which is free from one side. So these are the pictures X-ray. There is left-sided tension pneumothorax, and this has pushed the mediastinum to the right side. Now you will show the X-ray comment on this X-ray. Left-sided hypodense lung field with collapsed left lung margin with mediastinum shift towards the right, denoting left-sided tension pneumothorax. This can be due to refracture and surgical emphysema. How will you assess and manage the circulation component of a TLS? Assessment can be done clinically and by using non-invasive and invasive method. Non-invasive, check the pulse, check the capillary refill time, check the blood pressure, urine output, mentation. So these are non-invasive. In invasive, you put the central venous, you monitor the central venous pressure by Swan-Ganz catheter. Okay, this is classification of the different types of parameters. So class 1, class 2, and class 3 and class 4. So blood loss is less than 750 will be in class 1, 750 to 1500, 1500 to 2000, and greater than 2000. less than 15% blood loss. So this is in percent. Less than 15%, 15 to 30, greater 30 to 40, and greater than 40. Less than 100, greater than 100, and greater than 120 and greater than 140. And then blood pressure will be normal in class 1, class 2, and decrease in class 3 and 4. Respiratory rate 14 to 20, 20 to 30, 30 to 40, greater than 35. Greater than 30 ml urine output will be in class 1. 20 to 30, it will get decreased with class 5 to 15 in 3, and less than 5 in class 4. And symptoms normal, anxious, confused, and lethargic in class 4. Base deficit 0 to, this is not important, but you can remember it, like 0 to -2, -2 to -6, -6 to 10, and -10 or less. Need for blood products monitor, you can just monitor class 1. In class 2, you can possibly transfuse. In class 3, yes, you should do the transfusion as per need. But in class 3, you have to activate the massive transfusion protocol. Management of circulation. Stop any obvious source of bleeding by compression, external compression. Gain venous access by 2 large bore cannulas. Also take blood for cross match at the same time, and investigations as well, like full blood count, glucose, and urine electrolytes. Cross match for 4 units of blood. Commence IV fluid resuscitation. Okay, so you have to give the bolus like 500 ml in 15 minutes roughly, or you can give it according to weight, like 20 ml per kg. So like you calculate how much fluid, so then give it in 15 minutes. The bolus should be given in 15 minutes. You have to repeat this for 4 times, and after that you can like to give the maintenance fluid. Then if no improvement after 1.5 liter, non-responder or transit responder, so you have to transfer him to HDU, high dependency unit. Inform HDU registrar plus your consultant. Insert central line inotropes. Consider hemorrhage and start transfusion according to hemoglobin level. D. The disability component. As soon as the patient cardiopulmonary status is managed, perform a rapid focused neurological examination. This consists primarily of determining the patient's GCS, pupillary light response, focal neurological deficit. Exposure log roll maneuver is performed to evaluate spine and any posterior chest injuries. CT scan of this. Okay, so posterior chest injury, like posterior rib fracture. So remember, posterior rib fracture is not very common. It's only like it usually occurs in child abuse cases. The posterior rib fracture. Anterior rib fracture is very common in trauma, but the posterior is very rare. CT scan of this patient was done. Comment on this CT. So there is a rib liver laceration, which is probably grade 5 or grade 4. Most probably grade 4. So what are the gradings of liver tear? So this is like a nightmare for some guys. So we are going to make it easy. Like first, just go for the subcapsular hematoma. This will go up to like grade 4, grade 3, and in grade 4 and grade 5 and grade 6 does not include this. So from grade 1 to grade 3, subcapsular hematoma less than 10% surface area, then grade 2 10 to 50%, and then greater than 50%, this way. Then we come to the laceration. So laceration capsular tear less than 1 centimeter parenchymal depth, and then capsular laceration 1 to 3 centimeter parenchymal depth, and then greater than 3 centimeter parenchymal depth. Laceration less than 1, 1 to 3, and greater than 3. And then the hematoma, which is interparenchymal, it is only in grade 1 and grade 2 and grade 3. No, only in grade 2 and grade 3. In grade 2, the interparenchymal is less than 10 centimeter in diameter. This is interparenchymal hematoma. And in grade 3, it is greater than 10 centimeter interparenchymal hematoma or expanding. So this is done, and then we come to the grade 4, which is laceration, parenchymal disruption involving 25 to 75% of hepatic lobe or 1 to 3 conate segments. In grade 5, more than 3 conate segments or greater than 75% of the hepatic lobe laceration, parenchymal laceration. And then in 6, we have the hepatic hilum avulsion, like your portal and hepatic arteries, these are gone. In grade 5, also there can be juxtahepatic venous injuries like retro the suprahepatic inferior vena cava, or the retrohepatic inferior vena cava rupture, or the three hepatic veins, the right, middle, left. World Society of Emergency Surgery has presented the following classification utilizing the AAST grading system. Grade 1, minor hepatic injury, hemodynamic is stable, either blunt or penetrating lesions. Grade 2, moderate hepatic injury, yes, stable, either blunt. So this is actually World Society classification, and above one was American classification. So they are treating it, like comparing it with each other. So grade 1 in World Society of Emergency Surgery, so it will be like minor hepatic injury, 2 will be moderate hepatic injury, 3 will be severe hepatic injury. Grade 4 to 6 of AAST, stable. Grade 4 is severe hepatic injury. Grade 1 to 6 hemodynamically unstable. So in the other there can be stable, and in the grade 4 it will be severe hepatic injury, and it will include on the unstable injuries.